Some of you are here for the Roots of Toxicity conference, and I welcome you for that. This is a really kind of historic coming together of doctors and dentists from ICIM, which is the organization that I work for, the International College of Integrative Medicine. And my name is Wendy, and I'm the executive director. So if you call or email, you'll hit me. And I'm actually the only one who works for us. I'm the only one there, so you'll definitely talk to me. Also, we're with the environmental group, American Academy of Environmental Medicine. Hi, Alexander, welcome. And two other dental organizations, so we're really excited to come together for that. At the same time, in this room, we are welcoming our nurses and IV techs who are here for a whole weekend of chelation. So for the doctors and dentists who've come just for a day, there are nurses and techs mixed in with you who will be studying for 3 days. And if you have one of the red schedules, you'll see some of the things they're going to be working on later in the week. So for the doctors and dentists who are here just for a day, welcome. For the nurses who will be with us for the weekend, welcome. We are all going to come together to enjoy the wisdom of Dr. Chuck Adams, who is the ICIM president this year. And there is a lovely montage of his office right inside your syllabus. It is so much fun to go to our members' offices and see the stuff and the different personalities that come out through visiting someone's office. And Chuck has a very interesting establishment, and you'll hear a lot more about it. But do look at some of the pictures of his quirky and delightful office and staff. For now, I'm going to turn it over to Chuck, and he's going to do this the old-fashioned way, where he's not going to read off the screen. He's actually going to talk to you. And it's really, really kind of refreshing. He's given me notes from his lecture, which is what you'll find in your syllabus. These are they're exactly what they are. They're notes, and they're meant for you to go back and reference and to find things quickly. So enjoy and have a great morning.
One of ICIM's point, purpose, and function is to give you something that you can turn around and use on Monday. And towards that end, I made this. This is what's in your syllabus. You tell us which you like better, all right? Yeah. So, any feedback, please don't hesitate. Please give us feedback on this, because one of the reasons I didn't have a PowerPoint and all this other stuff, I'm technologically challenged. But also, this is something you're not going to have a PowerPoint set up in your office when you hire an employee. And so, this is something you can get off of our website. To reproduce, like if you wanted to train some employees that come in, what do y'all do here? How do we do this? And so hopefully it will serve that function. Now, what is in this is exactly what is in this. It's just formatted differently. And whichever format you like, go with it. I kind of like the bigger spacey out one, so I can kind of see what's going on. And whichever one you prefer, I'd like to know about it. Okay, because we could make either one of these versions available. I just like the one that's a little bit bigger, I guess, for slow readers or people a little slow out of the block. So, I'm an internist, an MD. Went to the University of Tennessee Medical School, did my residency in internal medicine at Chattanooga, and need more. And I'm going to go by this one, and it's got some reference, and so if that causes a problem, let me know. I can switch over. How I got into this, I was your middle of the road, hard going internist, and I had two different guys about 4 months apart. They both came in, and their stories were almost identical. Both of them congestive heart failure, taking nitroglycerin several times a day, water pills, swollen feet, beta blockers, and they refused bypass. And they went and got chelation therapy, and they're sitting there in front of me on no medicines and looking pretty darn healthy. And I'm like, oh my goodness, I don't this doesn't fit. I've never seen anything come out of the cath lab with these kind of results. It just doesn't happen. And so that's when I started checking things out for myself. And next thing I know, I'm teaching a class on chelation, the science of chelation therapy. The resource, if you look at this, I don't think I have but one or two references in this whole thing. And this is all stolen. I stole from everybody and everything, every lecture from the past. And one of the gospels that I tried to follow for the most part was this here, published by ICIM, written by Dr. Ted Rosema. In the early 80s, he and some other guys kind of helped form ICIM, and the original version of this was about that thick, and then in the early 90s, Ted thinned it down to this. And it's interesting, as I'm stealing stuff out of here, I've also got this Peter Van der Schaar, the clinical metal toxicology. This is part 1, this is part 2. And it's interesting, I don't know who stole from whom, but there's some things word for word. I don't know if Ted stole from Peter or Peter stole from Ted. It's like, but I stole from both of them. So your feedback would be greatly appreciated, because this is supposed to be a useful tool for you. And if so anything that's off, please. I'll have to get Wendy to help us get some feedback. So without further ado, we'll get started here on page 1. In the late 1800s, a chemist by the name of Alfred Werner was interested in bonding, and he came up with an idea called a complexion bond. And he felt that if you had a molecule that had a bunch of negatives out here, metals are positive, that you could get the metals out of the water with this. And then what's even cooler is if you could treat them chemically and reuse it over and over, it was a great business plan. And in 1913, he was awarded a Nobel Prize for this work in complexion chemistry. And I'm turning my phone off right now. I have a concierge practice. I just jumped out of all the insurances. And so this is the office phone and this is the personal phone. So they're dead. All right. 1920, Morgan and Drew said, instead of complexion, they wanted to rename it chelation. And chele is the Greek word for claw. And the chelating molecules, if you really use a lot of imagination, have a claw-like structure. And the tips of the claws have the minus charge. Metals have a plus charge, so you get the plus-minus thing going. And there you go. In 1933, Bursworth and Warren manufactured EDTA, ethylene diamine tetracetic acid. They manufactured it in 1933, and they finally got a patent on it in 1945. Well, over in Germany in 1935, Ferdinand Munz, he synthesized EDTA from nitrile triacetic acid, and he got a patent for Trilon B. And I'm not sure, but I think the German patent office kind of got messed up during World War II, so I don't know what happened to that. Now, caustic gases have long been used in warfare, and in World War II, the Germans came up with a gas, lewisite, that was arsenic and arsenic based, and so some of the British chemists came up with an antidote for that, and it was termed British anti-lewisite, or BAL. And so that was one of the first times that chelating agents were used in humans was under that pressure. In the late 40s, now I was not able to connect the dots, but somehow Abbott Labs, and I'm not sure if Bursworth and the other guy worked with Abbott Labs or what, but they began experimenting using the EDTA in, is it the purple top tube? Blue top, purple top? And so, and then in the early 50s, someone else playing around with the EDTA said, hey, it'll chelate lead. And lo and behold, here's a child that has lead poisoning. And so Dr. Bessman, and there was a lot of folks who said, don't you dare do that. It's kind of like the first surgical procedure. I don't know if y'all know about that, but there was a committee outside with a rope and horses for the surgeon after he finished his first surgery. But Bestman chelated lead out of a child. Wow. And the child lived and did better. In the early 50s in Detroit, there was an explosion at a battery plant. And Dr. Norman Clark happened to be on call that weekend to cover battery explosions. And so he treated the men there that got contaminated with lead with EDTA. Two of the men that were treated happened to have been his patients, and they had been having angina before the lead and before they were treated. And after they got through with their treatments, they came back to Dr. Clark and said, Dr. Clark, that lead is good stuff. I don't have any more chest pain. And luckily, Clark was curious enough that he began a series of papers and studies on folks, and that's kind of where the chelation therapy all began. And one of us, I think it's Dr. Tobridge, is going to give Dr. Chappell's going to give a history of chelation. I don't know if anyone's going to, but he'll probably go back over some of this, but he'll carry it on about some of the things that we've been through getting chelation up to the TAC study. And I can't help it, just Dr. Joe Holliday is a surgeon. And Athens, Tennessee is about halfway between Chattanooga and Knoxville. And he had patients that they met all the criteria for amputation. And he felt like, I just don't think I should amputate this limb, toe, or whatever. And so that's one of the things that got him into chelation. And he also had published a paper about how it can improve COPD, looking at pulmonary function tests. So I don't know if Joe's here this weekend or not, but good guy. Kind of neat to have a surgeon on board. All right. Meanwhile, back at the basic chemistry, and I think everybody in here has had just about as much chemistry or more. If some of you do know more about this than I do, please raise your hand and help clean it up for me, okay? Because I'm not a chemical guru by any means. I did teach high school chemistry for 3 years, but that was a long time ago. The periodic table of elements, and I left that in my office. I was going to bring one just for giggles and grins, but I forgot. Everybody can pull it up on the phone right now if you want. But an atom is made up of a central portion called the nucleus, and it has a proton in there which has a plus charge and a neutron which is neutral. And if some of you had chemistry recently, I still talk about them. I'm using my hands like they're nice little solid things, but now they're quarks, anti-quarks, negative quarks, positive quarks. I mean, it sounds like something out of Star Trek, but this is the E equals MC squared stuff. So I can still think of them as a nice little ball that's positive and no charge. And then outside are the electrons that have the negative charges, and it's the number of protons that defines which atom we're talking about. If it has one proton, it's hydrogen. If it has two protons, it's helium. If it has six, I think it's carbon. So that's how it goes. All right. And the electrons really don't circle. It's much stranger than that. It's amazing. One atom plus another atom makes a molecule. Molecules can be long, a whole bunch of atoms strung together. And one of the biggest ways to break up all the elements on the periodic chart is in metals and nonmetals. On page 3 there, metals conduct heat, conduct electricity. They're malleable. You can bend them, work them around. They readily give up electrons to become positive. Nonmetals basically don't do any of that. They don't conduct electricity. They don't conduct heat. They're brittle. They break. They readily take on electrons and will take a negative charge. All right, bonds. We already talked about Dr. Werner. There are two main categories of bonds. You've got the ionic bond, which is a bond between a positive ion and a negative ion, and they have a very strong attraction for one another. You have covalent bonds where the electrons are shared between one another, and then Dr. Werner came up with the chelation bond, which is a little bit like all of them put together. Rings. A homocyclic ring is a ring-shaped molecule, and the ring has all the same atoms in it. Like there's benzene, and the ring there is made up of nothing but carbon. And then on the next page is tetrahydrofolate, a cousin to folic acid, and it has homocyclic as well as heterocyclic rings in it. And so, and then right below that is, wait a minute, I got jumped over. I just couldn't help but put the glucose in there because glucose can either have the OH up or the OH down. It can be straight, it can be a ring. And then right below it is one of the most remarkable compounds on planet Earth, and that is vitamin C. On the next page, page 5, at the top there, that's one structure for, or one way to draw out ethylene diamine tetraacetic acid. There in the middle, you can see 2 carbons, CH2 and CH2. That's inorganic, that's ethyl. And then the ends to the left and right of the 2 carbons, those are the diamine. And then the COOs, that's the tetraacetic acid, so you got 4 of them. So ethylene, diamine, tetraacetic acid. And then below that is another representation of what, another way to look at EDTA. And here it has a metal in the middle. And that metal should have a plus on it, but that's the way it came across. So, any problems with any of this so far? So, oh yeah, we got a couple of really wonderful definitions. I'm going to have to read these because I refuse to memorize them. Chelate is a water-soluble complex between a metal ion and a complexing agent. And it may, this is a great definition here. I mean, someone doesn't have enough to do. An equilibrium reaction between a metal cation and a complexing agent characterized by the formation of more than one bond between the cation and the complexing agent, resulting in a heterocyclic ring structure incorporating the metal ion. I don't even understand that. But look at the picture. It's worth 1,000 words. Now, one of the neat things about EDTA is that it will chelate most metals. Fortunately, we don't have to worry about the temperature and pH because the body kind of keeps that pretty constant, so it's a constant milieu for these reactions to take place. And someone has measured the affinities that metals have for EDTA, and this is a little bit weird here. It's from the strongest to the weakest, and it shows mercury is having a very strong affinity for the EDTA molecule. But the problem is that EDTA does not chelate mercury that well. And one of the ways I explain that to my patients is that most of the metals will fit into the claw of the EDTA, but the mercury, the shape of mercury, it just kind of doesn't fit in. So if you use the right chelating agent for mercury, you can actually get it chelated out. We're going to talk about those in just a few minutes. Now, another factor as to which one of these things gets chelated is the concentration of what's around. And we have a lot of calcium and we should have a lot of magnesium, and so it can displace metals. That instead of chelating the metal, the heavy metal, you can chelate out the calcium and the magnesium, and you don't want that to happen. Now, this is one of the most important things that I'm going to say all day today, and y'all really need to pay attention. There's someone who just came in. Okay, thank you, ma'am. Super. There are 2 forms of EDTA that can be used, and the one that we use the most is disodium EDTA, or disodium edetate, or magnesium disodium EDTA. This one must be administered slowly. And if someone has normal renal function, it's 1 gram an hour or 3 grams over 3 hours. And some of the docs took a look at that and they asked the question, why do we do 3 grams over 3 hours? And the obvious reason was because that's the way we've always done it. And so they said, well, what if we did a gram and a half over an hour and a half? And supposedly that is as effective as the 3 hour. I don't know which one is more better than the other. It makes sense to me that 3 grams over, more time, more medicine, more of an exposure, you're going to get more of a result, but maybe it does not work that way. So It's either administered, you don't give 3 grams over an hour and a half. It's half the dose. It's still a gram an hour with normal renal function. Now, no, it doesn't. And we're going to talk about how to figure out how much EDTA does someone need. There's an equation to calculate that out. And so someone might calculate for 1 gram over 3 hours, depending on their kidney function. And so we'll come to that. Now, if you administer the disodium edetate too quickly, you will drop the calcium. This has killed people. There have been 3 people, 3 deaths that I know of, because it's been inappropriately administered. And so it must be administered slowly over time, and keep your eye on your patient because they'll turn the IV up on you. The other form of EDTA is calcium EDTA. It can be administered. I don't know if you have heard of a guy named Gary Gordon, and he was made a big whoop-de-doo. He nominated himself to be the father of chelation, and he was a big proponent of the. Need some more? Of doing the EDTA push, and the reality is that if you administer the disodium EDTA rapidly, you'll drop the calcium and people will die. And so the calcium EDTA, you can administer it as a push. It doesn't drop the serum calcium. It will pull out metals, but it doesn't seem to help circulation. So it's not that great for atherosclerosis. And so if you've got a patient whose family history is negative and they don't seem to have any apparent atherosclerosis and they're interested in getting rid of the metals, you can save them a little bit of time by doing the calcium EDTA. It's called a push, and Gary Gordon promoted it as a push. He was put in a syringe and push it in, and most folks said that wasn't a really good idea. It didn't work out, and so most of us will administer it as a 30-minute IV, which is a lot better than an hour and a half or 3 hours. But just heads up, never push the disodium EDTA because you will get in trouble and there's no defense for it. Okay. The absorption and metabolism of EDTA. The body doesn't do much with it. It comes in and it goes into the kidneys, into the renal tubules, but it doesn't filter it back out. Once it hits those tubules, it hits the bladder and out it goes. Its half-life in the blood is like 20 to 60 minutes, so it doesn't stay there very long. In the old days, and according to this, they would collect a 24-hour urine because that's how long you collected urines was for 24 hours. And a lot of folks looked at the dynamics and said, oh, wait a minute, most of it's gone at 6 hours. Why do we have to mess with this jug for 24 hours? So most of us now collect 6-hour urines to check for heavy metals. What about oral EDTA? We only absorb about 5% of it at the very most. And there are concerns that having EDTA in the gut, it might interfere with the body being able to absorb other metals and minerals. And so doing a lot of oral EDTA, probably not a good idea. Also, I don't know what would possess you to ever want to do this intramuscularly, but it's not a good idea. It hurts like the dickens. You can have some skin sloughing, so I don't think it's a good idea. The calcium EDTA, pretty much the same thing, gas and procaine, but just do it IV. Now, the disodium EDTA, as I said, will help the circulation. Or maybe I should say there's between an 80 and 90% chance, or odds are that it will help the circulation. Yes, sir. I haven't. Does anybody have any experience using the EDTA suppositories? Because it's interesting. I went over and hung out with Dr. Rosema for about a week in the late 90s when I realized, hey, I got to take a different path here. And at that time, they were doing the original work on the EDTA suppositories. And catch this, all right, the battery plant, the explosion was where? In Detroit. Well, that's awfully doggone dangerous. So they moved to the islands, little islands near the Philippines and all that like that. And they don't have any EPA, anything like that. So anything, I mean, it's just horrible. And the little kids can't walk. And that's where they would take the suppositories down there and see, and so I don't think it worked out as well as they hoped it would. So, I mean, it's a good thought, but I don't think it panned out. It's probably not going to hurt. It may help. So now, so how does it work? We don't know. There's some notions about how it might work. All right, the disodium EDTA will lower the calcium. That's why you administer it slowly. And so one thought is that the pituitary gland goes, oh my goodness, we're running low on calcium. The bones must be disintegrating. And so we're going to have to put the calcium back into the bones. And so the increased secretion of the parathyroid hormone, and that also has a vasodilatory effect. And the parathyroid hormone will also help move calcium out of the tissues to try to get it back into the bone, because the only reason that calcium could be, we could be losing calcium is because it all has to come from the bones. So that might be a mechanism. On page 8, if we have any platelet experts in here, please speak up, because some of this didn't make sense. I read it over 2 or 3 times and they didn't put it together as a good explanation. But another mechanism is the disodium EDTA seems to make the platelets less sticky. And so that helps with the circulation. And they talk about hidden proteins can now be inactivated by EDTA antibodies. But in the next paragraph, it talks about how EDTA transiently inhibits antibody formation. I don't understand that. So the antibodies, calcium, somehow all this stuff works together when you use the disodium EDTA to help improve circulation. Another thought is that removing the lead and the cadmium from the endothelium allows the endothelial enzymes to resume reparative mechanisms so that they can get back in the game, and that helps to improve circulation. And keep in mind that we only have about 60,000 miles of capillaries in our body, which is also endothelium. And so at what level, how it works, would be really, really interesting to see what falls out. And especially now that with TACT1, I've said TACT1 or 2 or 3 times. TACT was the trial to assess chelation therapy. It was an NIH-funded, double-blinded, randomized, placebo-controlled trial that was done in offices throughout the United States as well as Canada from 2002 to 2011. And in order to enroll a patient in TACT, they had to be over 50. They had to have a documented heart attack, no smoking for 3 months, no chelation for the past 5 years. Kidney function had to be okay. And the results from that, it proved that chelation is safe. And then it reduced the recurrent heart attacks in diabetics 40%. It reduced heart attacks in non-diabetics 20%. And so that kind of took away a lot of the medical board's concerns about, or one of their weapons they would use against us. It's never been studied. You don't know what you're doing. You're probably killing people. No one else does it. So stop doing it right now. We're going to take your license and, well, kind of good stuff. So chelation is now safe. And they're now signing up offices for TACT2, or enrolling offices for TACT2. And in TACT2, though, they're only looking at diabetics. And so you've got to be diabetic, over 50, documented heart attack, in order to get into TACT2. So, contraindications for toxicity, side effects, precautions, and frequency of infusions. And I don't think that follows the way that I went down below. If a patient has a severe allergic reaction to EDTA, don't give it to them again, unless you want to make a lawyer incredibly wealthy. And this one is, I don't know what the protocol is, because I'm not an emergency room doc, But if someone has a acute lead encephalopathy, you're not supposed to use EDTA by itself. I don't know exactly what the protocol is in that situation, but you've got to do some other things. And this person is going to show up in your office. Get them to the emergency room. Let them take care of it. Folks that have had like the post-polio syndrome or some kind of muscle weakness or muscular dystrophy, this might make them a little bit weaker. And so you might want to talk with them about this. You might try lowering the dose. I mean, it depends on what's going on. The gospel here is that the most frequently you can administer EDTA is every other day. And there was a physician in Virginia out in the middle of nowhere that had some property, would have places for people to stay, and people would come from all over and stay there, and they would do chelation 5 days a week, and nobody died. But the party line is, don't do it every day. Do it at the most frequent every other day. For example, if someone comes into your office, like the two guys I said, hey, they're in terrible shape, Monday, Wednesday, Friday, something like that would be the most frequently you'd want to do that. The TAC study, the model for them, for the TAC study, is there was 1 IV a week for 30 weeks, and then 1 IV a month for 10 months for a total of 40. And so what I do in my clinic, if someone's not under duress, and I just have a feeling that if they will do it once a week for the first 3, 4, 5, 6 weeks, and then every other week for whatever period, and then go to once a month, that's what I recommend in my clinic. I had one patient that when he went from every other week to once a month, the family urged him to go back to twice a month because he was a lot nicer when he did that. Anybody have any experience in, because I know some folks that do chelation in their clinics, yes or no? So we'll talk to folks around and see, because there's not, it's not nothing, none of this is hard gospel other than don't push the calcium, the disodium EDTA. You'll get in trouble. So it depends on the patient as to, and what's going on as to how frequently you infuse, do the infusions. Once a week, once every other week, once a month, just depends on the condition their condition is in. So, tell you what. The way I see this going is I plan on talking for about 40 minutes and then 10 minutes or so of Q&A and then 10 minutes of break. That sound good? And so we're kind of about there for right now. Does anybody have any thoughts? Yes, ma'am. It depends on, she asked how often do I do it in my clinic, and it depends on how messed up they are. If someone is in acute distress, taking nitroglycerins, doing it every other day, twice a week, is prudent and reasonable. Whereas if someone is doing it more for maintenance, preventive maintenance, or someone has stable angina, then might do it once. I'll offer them they can do it however as frequently as they wish. But then like I said, the first 3, 4, 5, 6, I'll try to do them once a week. And then separate them out. And I've had folks that have said, no, I need to go back to doing them once a week because my angina came back. And I'll say another thing too. I don't remember which presenter made this comment, but it rings true with me. If you do get someone in that is a vasculopath, has had a heart attack, is having angina, even if it is stable, those folks should probably do an IV, do a chelation every month forever and ever. Because they'll come in, they'll feel terrible, and then they'll do some chelations, and they'll get to feeling great, and they'll take off, and 6, 8 months later, boom, they've had a heart attack. And if someone will continue just to do it once a month, it doesn't seem to happen. And so, yes, sir.
That regimen that you were just talking about for the really bad patient versus the stable angina patient, are you talking about using disodium EDTA for that or calcium EDTA?
For a vasculopath, you would use the disodium EDTA because the calcium doesn't really help the circulation. Some folks feel that the calcium EDTA might be a little more effective at pulling out metals And so some clinics will use the calcium EDTA when they're going to do a urine provocation test. I'm going to talk about that a little bit later. So it's quarter till. Any other questions, comments, jokes? Yes, ma'am. I don't know if you can hear, she asked about the Myers cocktail. The Myers cocktail was concocted by Dr. John Myers in Baltimore. He did a bunch of neat stuff. I mean, really, and he came up with a concoction for the Myers cocktail. No one knows how he figured it out, and it's one of the most useful tools that we have in terms of IVs. However, whenever you do the EDTA, and I think I'm getting ready to talk about this when we come back, but if you take calcium and magnesium before you do a chelation treatment, you're not going to chelate out any heavy metals. You'll be chelating out the magnesium and the calcium you just took. And by the same token, after you have an IV, remember it takes a while for it has a half-life, 6 hours? Is that what it said? That you don't want to, once again, you knock the metal ions out and chelate out the magnesium and the calcium you just took. And so I don't remember exactly what all is in the Myers, but there's some other things that might interfere with it. And so generally speaking, with the EDTA, you don't administer anything else with it. Now, another thing we do in our clinic, where I tell folks the bell ringer for anti-aging is if you want to come in and do what's called a major autoheme therapy, and that's where we draw out 60 cc's of blood and mix it with 60 cc's of ozone and run their ozonated blood back in them, and then follow that with a chelation. And it could be either the calcium or the disodium, either one.
Why do you do that? Why do you do that?
Anti-aging. Ozone is good stuff. Really good stuff.
What does it do?
Why do we age? And the answer is the difference between us now and the difference between all of us 10, 20 years ago is our mitochondria's ability to make energy. And I'm getting off track here, but ozone, O3, is not all that stable. And when you put it into a living system, it very rapidly reacts with double bonds in amino acids and lipids. And the product of that reaction is exactly what the mitochondria need to get back to making energy. Do we follow that? Does that make any sense? Or so, but that's just something we do. Offer up. Yes, ma'am.
I know it's explanation, but over how long a period of time do you infuse your autoheme?
We run it back in as rapidly as the patient can take because you don't want it to clot. I mean, you mix it with that. There's a protocol for doing it, but it can clot, so you try to get it back in fairly rapidly. Yeah. She asked, is it a Schallenberger technique? And it's interesting. Break time. See you back at 9 o'clock. Got about 10 minutes here.